What are the key challenges in global healthcare that demand our immediate attention as the world continues to grapple with COVID-19? At Medical Korea 2022, we're discussing ways to foster international collaboration in healthcare and create mutually beneficial outcomes that will benefit all of humankind. Stay with us to find out more about the smart, future-oriented solutions that are on the table to improve our healthcare systems.
Hello everyone, you're joining us on Medical Korea 2022 Global Healthcare and Medical Tourism Conference. I'm your host, Na-hyun-kyung. We as human beings are naturally bound to have a vested interest in the healthcare sector, so just like part 1, we have many stellar experts related to the healthcare industry lined up for you in part 2, and we'll discuss the latest trends in this sector, so I do hope that you will stay with us throughout part 2 of our conference. So let's get to it right away, shall we? Let's meet our very first speaker of this session.
What changes will healthcare bring to American society? The U.S. is the largest healthcare market and wields significant influence on global healthcare. So what is the outlook of the industry in the U.S. and how might cutting-edge technology and healthcare drive innovation in the delivery of medical care and services? Let's find out.
Just like any other sector, scientific and technological advancements are changing the landscape of the healthcare industry. And as you just saw, the U.S. remains the world's largest healthcare market. So let's invite Dr. David Bates to find out more about the latest trends and listen to what's been going on over in the U.S. Dr. Bates, welcome to our program.
I'm David Bates. I'm the chief of the Division of General Internal Medicine at Brigham and Women's Hospital and a professor of medicine at Harvard Medical School. And it's a pleasure to have a chance to speak with you today. I'll be talking about new directions of development in the U.S. healthcare industry, focus on healthcare information technology. So where are we today in U.S. healthcare? The costs of care are high, and yet our quality ratings are low, and the care is the world's most expensive. We still have many errors, which have a high toll in terms of patient safety. There are large gaps between evidence and practice, and many guidelines are not followed. We have increasing use of technology, but its use is often suboptimal. Clinicians have many answers today that don't get answered. And yet there are vast quantities of new knowledge. All that, of course, is available on the internet, and we have the emergence of genomics. And at the end of the day, there are many opportunities for improvement. This slide just illustrates graphically what I showed you before. This looks at the average spending on healthcare per capita. And you can see that the U.S. is at the top, and we spend nearly twice what any other nation in the world does on healthcare. And if you look at expenditures on health as a proportion of GDP, that figure is also very high and out of proportion to other countries. And yet, if you look at our quality ratings, they're relatively low. The U.S. ranks near the bottom in terms of quality of care, in terms of access to care. It's at the very bottom in terms of efficiency of care and equity of care. And patients in this country, despite all the money that we spend, don't live longer, healthier, more productive lives than in other countries. Now, that has resulted in major federal policy changes, and those have some spin-off implications. The government under President Obama recognized the role of healthcare IT in spades. Trump did not change things very much, and there's been a renewed emphasis on healthcare IT under President Biden. We're just through the most exciting time ever in healthcare IT, in which there was a huge federal investment of approximately $27 billion that was made. And that is only a down payment, but it's clear that we are going to be using healthcare IT going forward. And what those dollars were used for was to incent hospitals and doctors' offices to adopt healthcare IT, and that did indeed result in widespread adoption of electronic health records. Nearly all hospitals and outpatient settings in the U.S. now use electronic health records. But at the same time, we are still not getting major safety and quality benefits that were expected from that investment. Now, more broadly, we've also undertaken healthcare reform. The Obama administration passed what's called the Affordable Care Act, which provides access to all patients. Before that, we were the only major industrialized nation that did not do that, and it's been a big step forward. It includes incentives to improve costs, quality, and efficiency. It sets up what are called accountable care organizations, which are organizations that get paid based on how good the care that they deliver is. And it also offers some payment through bundling, in which an organization will get paid a specific amount of money to care for a population of patients. Now, many have questioned whether pressure on costs will be sufficient to make a difference, and that's still not clear. It's still politically contentious. We do not in the U.S. have a strong movement to a single payer system. And the main focus really is on accountable care, and organizations are asked to be accountable for populations. And that's relevant to any company that's thinking of moving to the United States. There are three main areas of innovation in healthcare right now. Those are pharma and biotech, devices, and healthcare IT. And I'll focus mostly on the last of these two, but it's important to mention the first two as well. So in terms of pharma and biotech, the activity continued to be really high. As just one example, in quarters 1 to 3 of 2015, there were 268 deals worth $231 billion. And that was a big increase over the same period the previous year. A couple of examples include Teva's $40.5 billion acquisition of Allergan's generics business. And another example is AbbVie paying $21 billion for pharmacocyclics, which makes a novel blood cancer treatment. With respect to devices, there's also lots going on. You're seeing development of strategic partnerships with large acquisition volumes, and also a lot of development in the areas of diagnostics and biotechnology. There's in particular a precision medicine emphasis with dynamics between diagnostics and biotechnology evolving. Healthcare IT has also been a very hot sector. So here are some data that just looked at what happened between 2009 and 2014, and you can see that there's a very big upturn in digital health deals and in investments, and that's gradually gone up. And there are very large numbers of venture deals over this period. So now I'm going to just move to a view from the healthcare side. I'm at a big hospital, Brigham and Women's Hospital, and I want to explain to you what things look like for us in terms of accountable care. We're part of MGB Healthcare, which is the biggest integrated delivery system in the Northeast. At the Brigham, about 1/3 of our population is in some sort of ACO-like arrangement, either a pioneer ACO or through our commercial payers. So for example, Blue Cross, which is the largest commercial payer, has something called the Alternative Quality Contract. But that means that 2/3 of our population is still not in an ACO-like arrangement. So we're still being paid fee for service. There's no bundling yet, but there are active conversations about it. And, I think that one of the biggest innovations is the use of big data in clinical care. This is a paper that I published back in Health Affairs with a number of collaborators, and we argued that there are 6 use cases that would deliver the most value to healthcare systems. Those are managing high-cost patients, looking at readmissions and trying to reduce the frequency of readmissions, making better triage decisions, that is to say, putting patients in the right place for them when they come in to an institution, identifying decompensation, detecting and mitigating the risk of adverse events, and then finally optimizing treatment, especially for patients with chronic conditions. Our hospital has a innovation center called the iHub, as do many other large hospitals. And our mission and vision is to be seen as the leader to work with in healthcare innovation. And we're trying to foster innovation through collaboration and transform ideas from creation to dissemination, unleashing our potential to disrupt traditional medicine and reinvent healthcare. And that often means working with companies from the outside who bring something to the table that we think will be helpful. And at the end of the day, the goal is to create new revenue streams for the hospital and to make the hospital work more efficiently. A number of other big academic institutions have done this as well. And I just want to take you through some of these so you get a sense of what the focus is, because it varies some from institution. So for example, the Mayo Clinic has a very big innovation group, and they focus both on clinical innovation and investment in outside opportunities. The University of Pittsburgh has been very successful by investing in small companies and then co-developing with them, and they've been a very good partner. The University of Pennsylvania's innovation operation is focused on innovation around care redesign, so that's a much more internally focused kind of operation. And UCSF, the University of California, San Francisco, has developed a center to enable testing of mobile applications. All of these are interested in evaluating and partnering with companies with new ideas and solutions. So what should the view from overseas look like, and what's the role of official development assistance? Well, Korea has been a leader in this area, and in 2020, Korea spent US $2.2 billion on official development assistance. And that corresponds to 0.14% of South Korea's gross national income, so it's a significant investment. And again, the U.S. is the world's largest healthcare market. Almost all companies that want to be successful eventually want to try and enter this market. I have a few specific suggestions for companies thinking about entering the U.S. market. Again, the most important focus here is costs. So it's very helpful if you have something that will help us reduce our costs in some way. Many institutions are still reeling from COVID and have trouble thinking about making arrangements with new companies, but hopefully we're getting close to the end of this pandemic. And once that happens, I think we'll see much more interaction with outside companies. You do need a partner to work with, and most often that will be a large academic institution. Doesn't have to be, but part of the reason I mentioned the large academic institutions is to give you some sense of who some of the big players are and what their focus is. It's very important to have evidence to show what you have to offer works. We have so many opportunities to work with companies that if you can't make that argument clearly, it will be difficult for you. And again, for organizations, there's great concern about costs across the continuum of care. So even after the patient leaves the hospital, actually more of the costs are outside the hospital than inside the hospital, and yet institutions haven't figured out how to deal with things outside the hospital. So that's a big opportunity. So to wrap up, this is a very exciting time in healthcare. There's lots of innovation going on. Again, the major driver in the US is high costs. We're seeing very rapid changes in the IT space. And there are many opportunities to make care better and rethink how things are done. And companies from the outside can be a key player in helping us do that. Thank you very much.
Well, thank you very much, Dr. Bates. A very exciting time indeed. You mentioned a collaboration between hospitals and outside organizations, and you've also given us tips on entering the U.S. market. So what kind of impact do you think these types of collaboration will have on the bigger international healthcare arena?
Well, I think there will be more cooperation going forward. And, particular areas of opportunity include approaches that focus on big data and on the use, for example, of artificial intelligence and integrating that into care routinely. We now have more and more access to approaches that will make predictions But what we're not so good at so far is getting those predictions to the individuals who are making the decisions and then changing the way that decisions are made and in ways that will make care better. So, again, I think there are many opportunities for companies, and the key is to make it clear how your innovation will help an individual organization.
And speaking of opportunities and collaboration, what kind of role do you think Korea can assume in the bigger international healthcare sector?
I expect Korea to be a huge part of development in the medical sector going forward. Obviously, it's already had many successes with companies like Samsung and others, and it is one of the very best countries in the world at developing new information technologies and new IT tools. So I think this will be one of the most important spaces for it going forward. And arguably in the US, our single biggest problem right now is healthcare costs. So any technologies that will reduce the costs of healthcare in the US will be very well received in this country. And I expect that some of the ones that will help us do that are going to come from Korea.
All right, thank you very much, Dr. Bates. And I do also hope that Korea will continue to collaborate well with its international partners. And thank you once again for sharing your thoughts with us today.
COVID-19 has laid bare the health disparities seen in countries across the globe. What is Korea's role in bringing equitable medical services to the people and ensure healthier lives for global citizens?
There's no doubt that we will continue to see growing and wider cooperation in the field of medicine in the global arena. Different countries will have come up with different strategies to overcome some challenges. So what about Korea? How is Korea envisioning its role in promoting public health and healthcare in general? Let's now turn to Dr. Lee Jong-koo, a professor from Seoul National University, for more. Welcome to our conference, Dr. Lee.
Hi, I'm Lee Jong-koo. It is an honor for me to speak about our COVID-19 experiences and cooperation in the Republic of Korea. My presentation will cover a variety of topics, including pandemic situation, the concept of global security, and how we respond to and to where we need to go. Will this pandemic be the worst in a century? This week have seen the highest number of patients and deaths. Many pandemic disease game changers like influenza outbreak in Spain, Hong Kong, Russia, and avian influenza. Current flag in Madagascar have occurred in the last 100 years. We've developed quick response to microorganism challenges and adapted to threats, allowing us to survive. The influenza outbreak in Spain was the worst, but there will be more 500 million cases worldwide in this pandemic. When a new illness occurs, it spreads from its epicenter throughout the rest of the world in the absence of population immunities. However, if people obtain the immunity to the infection or immunization against the disease may be eradicated or endemic, in which case it circulates annually. But we are not yet at the peak of the outbreak. It will be require or maybe require more deaths, and we have already suffered many victims. Officially, there have been 5.8 million deaths registered across the world. But we have information on more than 4 or 5 times that amount of excess mortality. And the COVID-19 outbreak has disrupted National Health Service in about 94% of the countries, which may be one of the causes of excess mortality. In May 2020, Lancet Richard Hurton states that this current pandemic is unlikely to be the last or the greatest global health crisis of the century. And then, more importantly, this global calamity is not the health crisis. It is our responsibility to understand what this disease means to the lives of those who has been affected, and to utilize that knowledge not only to change our perception of the world, but also to change the world itself. These critiques may serve as the starting point for a discussion on planetary sustainability and solidarity. If there are no medicines or vaccines to manage this sickness, all countries have always relied on lockdown to contain disease, like the governor did in the 14th centuries. This slide shows the first and second quarantine offices. Now we'll look at how we dealt with the threat of infectious disease historically. 30 years ago, in 1992, a landmark Institute of Medicine paper titled Emerging Infectious Disease, Microbial Threat to Human Health in United States emphasized the critical but sometimes overlooked topic of emerging infectious disease. A review of the progress made and the setback discovered over the last 2 decades indicate that despite the emergence of numerous new diseases such as 2006 SARS and 2009 pandemic influenza, significant advances in EID control, prevention, and treats have occurred. Numerous factors contributed to the increased capability to control EIDs, including breakthroughs in microbial detection and treatments related to genomics, improved disease surveillance, and increased understanding of EID, and intricate the circumstances that contributed to their formation. Looking back over the last 2 decades, it is clear that we are living in the period of rapid change, in which both the EID challenge and our solution to it was undergoing transformation. Recent advancement supports guided optimism that further breakthroughs are on the way. The WHO derived its authorities from the international health regulation enacted in response to cholera. Unlike the majority of international organizations, WHO has 6 regional offices with representatives from each country who serve as technical advisors and educators. In other words, even when difficulties arise on site, regional office on the 6 continents or national representatives do not respond directly to on-site response and respect sovereign states. However, this position was changed as a result of simultaneous health crises in several countries caused by avian influenza human infection and SARS. Since the need for organization became clear, the WHO amended the IHR in 2005 to resolve all instances that caused health risk at their source rather than closing borders and managing them in real time. Preparation and prevention of casting, early detection and notification of countermeasures are regarding to be critical means. However, the border control issues received little attention on this pandemic, despite the fact that it violates WHO's basic policies. In March 2020, the sixth global health crisis was declared. It is issued according to whether the impact on public health is very significant, unexpected, high risk of international transmission, high risk to limited international exchange and trade. Most of the death statistics are centered on hospital-confirmed COVID-19, but in fact, people coming to the hospital, deaths in nursing home were thought to have been largely omitted as they were not even confirmed. In addition to the direct treatment of patients in hospital with COVID-19, the disruption of the healthcare delivery system, suspension of vaccination program, and the support of chronic disease due to COVID-19 also appear to have contributed to excess mortalities. The WHO survey of 135 countries twice showed that 9% were 75% to 100%, and 60% of countries without any damage at all. In order to manage this disease, considering the 2009-2010 pandemic influenza experience, it is judged that disease management is possible only when the supply of diagnostics, therapeutics, vaccines, and health systems are improved. We wanted to respond by creating an accelerator. In particular, effort to vaccine production should be further advanced. A scale of strategy should be prepared, and we will have to take a good look in South Africa's messenger RNA vaccine at what role we can play in the spoken herd model. Let me inform you about the situation in Republic of Korea. Let me show our experiences. Flattening the epic curve in the early stage could be due to contact tracing of householders, targeted PCR testing, quarantine and isolation to prevent virus spread, and the severity-based treatment of positive cases to avoid the shutdown the healthcare system. Although the current vaccination rate is very high, Omicron's transmission rate is 1.6 times higher than Delta due to the immune escape and reinfection. As the number of cases increase, the overall number of cases is almost the same as before, even though more than 60% of vaccination were performed last year. And countries with low vaccination rate have a high probability of new epidemics, so the WHO is working to ensure that 70% of the world's population can be vaccinated at least once before July of this year. It was usual that in 2 or 3 weeks, we can see a surge after lifting the social distance and a decrease in confirmed cases after reinforcing the social distance. But we cannot see these effects in this Omicron. Mobility restriction may not make effect on control of this disease. We are considering continuing to maintain lifting level, not to reintroducing higher level of restriction. This disease requires additional social and economic security for the vulnerable classes, low income, old age, and obese people. So the Korean government, like other countries, protect them through disaster subsidies or the compensation small company owners for lost income. Meanwhile, the issue of governance in the management of this disease has been taken very seriously. Political leaders was abusing unscientific message to create favorable conditions for election and communication. Participation of local residents are critical to properly sharing each country's experiences. In this regard, the Republic of Korea has become a model for other countries. This is the last section of my presentation. Where should we go? This pandemic will soon be over, but we must prepare for the next one, which will keep the world safe from pandemic. Because of our potential to escape natural immunities and vaccine-induced immunities, the development of next generation vaccine that elicits broadly neutralized activity against current and potential future variants is a top priority. Meanwhile, we must continue to reduce the risk of new variants through low viral replications and transmission by continuing non-pharmaceutical intervention, surveillance of virus sequence, and accelerate equitable vaccine rollout globally, as no single country can afford to relax its guard while escape variants developed in other parts of the world. We are considering collaborating with other countries for potential area in the future. For example, in Section 1, co-sharing current experiences, border control, screen tests, outbreak data, virus characteristics. Section 2 is clinical experiences and the data exchange of the severe patient care and medical training. Section 3, personnel training program for therapeutics, vaccines, diagnostics, and laboratory and epidemiology research. Section 4 is the production and the stockpile of PPE, ventilators, diagnostics, and drugs. It would be appreciated if the academic alliance against COVID-19 between universities could be visualized as soon as possible following government meeting. To eradicate COVID-19, we collaborate with other countries to develop the health system, including not just the COVID-19 control program, but also general healthcare system, which including universal health coverage. This can be accomplished through bilateral cooperation with low-income and middle-income countries, as well as multilateral cooperation with regional international organizations such as ASEAN 3 countries, with WHO and the UN serving as key element in health diplomacy. This figure describes the WHO health system framework, 6 building block concept: governance, finance, health workforce, information system, supply management system, and health service delivery. Our aid should be directed toward supporting the recipient country's health system, and it is crucial to tailor the COVID-19 aid plan based on each country's components: supply chains, vaccine coverage, training and education, information technology, system design, even though which already been completed. We are involved in helping to building the health systems of other countries, not only directly but also through WHO, which support low-income countries with donation of personal protective equipment, vaccine, and experts to respond to this pandemic. But we also discussed preparedness. Preparedness entails a shift in WHO governance, including the implementation of the international health regulation and signing of our new pandemic prevention treaties. The origin of COVID-19 is a hot topic in the fighting against the new disease, and funding to develop the health system in low countries is crucial to new treaties. It would be wonderful for Korean government to be invited to international society. In conclusion, to summarize, no one is safe from COVID-19 until everyone is safe. As a result, the success and failure of the Korean government will be helpful to other countries, and the Korean government will continue to make effort for international cooperation to prevent emerging disease and strengthen the health system of low-income countries and middle-income countries. According to the Tedros, the COVID-19 pandemic will not be the last. However, Lee Jong-koo, late DG WHO, said that we will progress toward the goal of health for all. By working together and learning from history, we can change the future of global public health. Thank you very much for your attention.
Well, thank you very much, Professor. I think the very purpose of this event, Medical Korea 2022, is to foster and promote international collaboration. So you did a good job in reminding all of us of the role that we can play to promote more growth and find mutually beneficial ties. So thank you very much for speaking to us today.
나이가 먹으면 버는 비용이 없기 때문에 치료에 대한 그런 부담감이 많이 있으니까
부모님들께서 뭐 아프셔도 저희가 직접 핸드폰 어플 같은 걸로 알아볼 수 있게 뭐 그런 게 개발이 돼서 좀 걱정 없이 부모님 안부를 다 챙겨볼 수 있는 그런 세상이 됐으면 좋겠습니다.
나이가 들면 우리가 이제 일을 할 수 없는 상황이 되는데 그러면 이제 돈도 없고 이런 상황에서 큰 병에 걸리면 자식들한테 부담도 많이 가고
이제 노후가 되면은 아무래도 혼자 살 수도 있을 텐데 그럴 때는 이제 병원을 가는 것도 힘들 거고 그러는 게 좀 가장 걱정이 돼요. 혼자서 이제 아프면은 많이 힘드니까.
From the street interviews, it looks apparent that one of the most concerning elements in healthcare for people is aging. And they're also aware of the potential issues that may arise from this aging society. So the provision of elderly care has become a focus of the healthcare industry and medical research. Now, on that note, let's welcome Professor George Demiris from the University of Pennsylvania to learn more about how our healthcare systems can be adapted to an aging population. Thank you for talking to us today, Professor.
My name is George Demiris. I'm from the University of Pennsylvania, and today I'll be talking about ways to create smart communities for the future of aging. We are facing changing demographics globally, and the segment of the population that's 65 years of age or older keeps growing, while at the same time we're experiencing workforce shortages. So we're clearly facing unique challenges in trying to deliver high quality care for older adults, with the vast majority of people over 65 wanting to age in place, meaning to stay at the residence of their choice for as long as possible, rather than change residence or setting of care every time their care needs change. So we hope that technology can actually provide a solution, and we look at digital tools as a way to promote monitoring and also facilitate interventions for aging in place. One such category of technologies focuses on behavioral sensing, and more specifically passive monitoring and wearable technologies, where the vision is to objectively, remotely, and continuously measure aspects of patient physiology, behaviors, and symptoms. The advantage that we have with these types of behavioral sensing technologies is that we can actually capture behaviors and activities of daily living without needing human observers, and without having to rely on self-report, which, as we know, can be problematic sometimes because of the recall bias that it introduces. Additionally, those digital tools allow us to shift from episodic to continuous monitoring, assessing people in the real world and not in a laboratory, with the goal to collect data so we can actually develop algorithms that will help us identify events, trends, and patterns in the data, so we can shift from a reactive to a proactive model of care. And one such example of behavioral sensing in the home is what we would call a smart home. A smart home is broadly defined as a residence with embedded technology that facilitates passive monitoring of residents to enhance their safety, independence, and well-being. So imagine a residential setting where we use different sensors, such as motion sensors that can tell us when somebody is moving or resting, bed sensors that can give us information about sleep quality, restlessness at night, bathroom visits, door sensors and window sensors that allow us to make inferences about time spent inside the home versus outside the home, number of visitors, engagement in meal preparation or daily hygiene. Those are all data that can actually help us understand what is going on with somebody's life, and in some cases help us potentially prevent an adverse event before it occurs. And so that is a shift from a model where we actually have to deal with the adverse event and try and minimize its catastrophic consequences. A very typical example with smart homes is the detection of urinary tract infection. You can very easily identify that somebody's number of bathroom visits per night, for example, increases significantly in a very short period of time. And that data can lead to a diagnosis that could, when taking place early on, prevent unnecessary rehospitalizations. There's also other examples that can show when somebody's experiencing more social isolation or engages in more sedentary behavior and their mobility becomes more limited over time. Having such rich data sets gives us the opportunity to visualize information about activities of daily living. And that visualization can sometimes provide new insights and allow us to be more proactive. Here you see some examples of different graphs that capture data from sensors and portray activity in the home over a certain period of time. And in this graph, you see what we call density maps. So you can see somebody who's spending time inside the home versus outside the home. In this example, black identifies time outside the home, and then the whole spectrum shows the level of mobility inside the home. So basically, these two graphs are 1 year apart, but show one resident who had a very regular daily schedule, shifting to one that's quite unpredictable, with poor sleep quality and even time spent outside the home after hours. So that's an example of somebody who may not necessarily show a decline in their physiological symptoms, like the blood pressure, but they're actually experiencing some cognitive decline that leads to this irregularity in their activities of daily living. Another example of a smart home system I wanted to present briefly is a project we call Sense for Safety. And here we're looking at smart technologies for fall risk assessment and fall prevention for socially vulnerable older adults with mild cognitive impairment. The Sense for Safety intervention targets people with mild cognitive impairment because mild cognitive impairment and housing conditions are each independent risk factors for multiple falls. As a matter of fact, cognitive impairment is a leading risk factor for falls in older adults, and over 60% of older adults with mild cognitive impairment will fall annually. That's 2 to 3 times the rate of those without cognitive impairment. And also people living in low-resource neighborhoods with poor housing conditions have twice the risk of falling. So we're looking at an intervention that will use smart home technology to actually link at-risk older adults with a nurse telecoach who will guide them in implementing evidence-based individualized plans to reduce fall risk. we're partnering with engineers from the University of Missouri to actually use this technology to identify escalating risks for falls real time through in-home passive sensor monitoring. And the technology uses machine learning to inform individualized plans to reduce fall risk. The depth sensors create those silhouette extractions where you can actually get a lot of information about gait characteristics, and the system lets you calculate stride length, gait speed, and other characteristics that are important so you can basically calculate a fall risk score for an individual. There is a dashboard that allows for the nurse to look at the fall risk predictions and fall risk calculations over time, as well as annotate with information about health-related events that help you understand potential changes in gait. And that also informs an intervention, whether it's an educational or exercise intervention, that can hopefully minimize the fall risk that's identified through the technology. Another area where smart home technologies and smart communities can actually play a significant role is that in social engagement. We know that social isolation and loneliness are significant risk factors for older adults, and it's actually a phenomenon that's increasing in prevalence, especially in the Western world. And social isolation has significant health impacts for older adults. When we think about smart communities, we can actually use that same platform as a way to promote engagement. This can be done through passive sensing, like the smart home projects that I highlighted earlier. Smart home sensors can be used to detect how much time people are spending alone and whether their social network might be decreasing, whether they're engaging in more sedentary behavior or less time outside the home. And that can inform interventions to promote engagement. That can be useful intervention for activities directors in these facilities or volunteers who can better understand the social needs of a community. Additionally, we have digital tools like conversational agents and chatbots that could potentially play a role in providing opportunities for social engagement for older adults who are isolated. And finally, when we think about these technologies, they can facilitate community-level planning by allowing us to better understand how members of a smart community are connected to each other, or how we can strengthen those ties and connections between individual community members. As we think about these technologies in the home, one factor that we do need to take into consideration is the concept of obtrusiveness. And we define obtrusiveness as a summary evaluation by the user based on the characteristics or effects that the technology has that may be perceived as undesirable and physically or psychologically prominent. In other words, we need to understand the lived experience of people who adopt these technologies in their own homes and communities. When we think about the obtrusiveness framework, it's not only the issue of privacy, which is a significant aspect in terms of adopting these technologies in the home, but we also have to understand the issues of how the technology interferes with daily living, the usability aspects, the physical dimension, the functional dimension, and many others, better focusing on how the technology may replace or affect human relationships and how it may impact one's own perception of their own loss of independence, as well as how technologies may be causing embarrassment or stigma and may be interfering with daily routines. So it is a complex phenomenon that needs to be examined more holistically if we want to better understand acceptance and diffusion of those smart tools for individuals and communities. We have to understand how these technologies may address health disparities. We develop technologies with the hope that they will be eliminating health disparities, but sometimes we see that technologies may exacerbate such disparities. How people fully understand what they're signing up for and how we can achieve informed consent for people who may have different levels of experience with the technology. How we can help patients navigate through these new complexities, recognizing that people have different health and digital literacy, how we can solicit patient and family preferences and understand that these new smart tools may be changing the process of healthcare delivery. In gerontology, we have to think of cases where an individual and their family members may have different needs and preferences and how to deal with situations when one cannot make decisions for themselves. Think of these technologies as a unique way to enhance social aspects of care and understand ways the smart communities can actually promote social engagement. With that, I want to thank you for your attention, and I'm happy to answer any questions you may have. Feel free to contact me for any comments or feedback. Thank you.
Well, thank you very much, Professor. You've covered quite a few bases for us, and smart communities certainly do look to be a promising solution for alleviating the multitude of challenges that the aging society may bring. With that said, how can this idea be adopted on a global scale?
It's really important to promote global cooperation in terms of designing and implementing and evaluating technologies that support aging. The trends we see in aging are affecting countries globally, and we have to learn from each other in terms of not only new technologies and new tools, but also innovative models of care and policies that can facilitate and improve care for older adults. This collaboration needs to happen at a global level to ensure that we have not only innovative solutions that can be easily adapted in different settings, but also to promote interdisciplinary dialogue. I think it's important to invite experts globally to come up with common solutions that will help us come up with new ways for old problems. And in this case, also think about emerging trends that can provide unique opportunities for healthcare. We have a lot to learn from other industries, and I think in healthcare, bringing together the synergy of clinical, industry, and academic partnerships at a global scale can really advance the development of smart tools for aging.
Well, thank you very much for talking to us today. I think I was very glad to learn that we are not alone in facing these challenges, and that there are ways to really meet the needs and unique requirements from or of different countries. So thank you very much for talking to us today once again, Professor. An unexpected battle with a global pandemic and efforts to address an aging society stemming from longer life expectancies, they all come with the need for providing creative solutions from the healthcare industry. As more challenges emerge, even more expectations will be placed on this sector to deliver effective remedies which will hopefully spur more progress and healthy competition in the market. Well, that's all we have prepared for you in this segment of the conference. I hope you were able to learn and pick up a few ideas through both Part 1 and 2 of Medical Korea 2022 Global Healthcare and Medical Tourism Conference. Thank you all very much for watching.